Hello everyone and welcome to our new case. This is a 50-year-old female coming with bilateral loin pains. This is the CT of patient. As you can see, this is axial cut of our dynamic CT. You can see here bilateral hydroureter nephrosis. There is a soft tissue mass seen surrounding the aorta and IVC and both iliac vessels. Also, you can see there is a hyperdense material is seen within the dependent border of the gallbladder. We can see both ureter are attenuated with subsequent hydroureter and hydronephrosis. This is axial. This is the coronal cuts of our CT. Also, you can see here the soft tissue are surrounding both aorta and IVC and iliac vessels. In the sagittal, you can see the extension of the soft tissue from L2 to about L4. We can see in the delayed phases, the right kidney, there is a delayed excretion of the contrast in comparing to the left kidney, denoting aggressive obstruction more than the left. This is a classic picture of retroperitoneal fibrosis. Retroperitoneal fibrosis is a condition. It was previously called chronic periaortitis. It is an uncommon fibrotic action in the retroperitoneal. Usually, a patient presents with ureteric obstruction. It can occur also in female, although it is predominant in males. Idiopathic retroperitoneal fibrosis is a subtype of retroperitoneal fibrosis. In idiopathic, we can't define any cause. And usually, as patient present with ureteric obstruction, either bilateral or unilateral. Our case coming with ureteric obstruction symptoms. And our CT show the classic radiological find. So what is meant by idiopathic retroperitoneal fibrosis? It was called previously by Ormond disease. It's subtype of retroperitoneal fibrosis, and it is called idiopathic because we doesn't find any obvious cause. It characterized by a fibro-inflammatory tissue encasing aorta and iliac arteries. It may extend into the retroperitoneum and often enveloping the adjacent structures, for example, the ureter as we see in our case. Our retroperitoneal fibrosis may be associated with other autoimmune processes, suggesting it may be due to an autoimmune pathology. We can see the disease in primary biliary cholangitis, fibrosing mediastinitis, glomerulonephritis, pain, hypopituitarism, ankylosing spondylitis, rheumatoid arthritis, polyarthritis nodosa, systemic lupus, Hashimoto thyroiditis, IG4 related disease, and all these diseases are autoimmune. What we can see in our radiological feature, it appears as a contrast enhancing fibrosis is seen encasing the retroperitoneal structures. It can cause ureteric and vascular obstruction and displacement with no other demonstrable alternative condition or malignancy. Contrast enhanced pericoronary artery tissue proliferations, Mistelju sign, have been reported in some patients. The disease can lead to acute renal failure due to periureteric involvement, and this require urgent intervention. The medical treatment usually involve corticosteroid with or without other immunomodulating medication such as tamoxifen. In case of periureter or perivascular involvement, surgical intervention may be indicated. This is our case today. Thank you and see you in next lecture.